Hi guys, we're moving on to the second part of endocrine diseases. So here we go. Starting with diseases of the adrenal cortex. And the first one I want to talk about is Cushing syndrome. Cushing syndrome is an excess of glucocorticoids, or it could be a tumor of the pituitary, either way. When we think about it again, the anterior pituitary releases our adrenal corticotropic stimulating hormones, and it tells the adrenal cortex to do its job. So we have an excess of glucocorticoids, and it can be because of the adrenal cortex or the pituitary. Here is a picture here of a little boy who actually had a adrenal tumor, and so you can see with the Cushing syndrome, we see a lot of thickening of everything. When we look at Cushing or look at glucocorticoids, what do? They stimulate the release of glucose. So, with our patients, we're going to see weight gain. They have an upper body obesity, moon face, or this rounded face. They're actually going to develop what's known as a buffalo hump, and it's just an excess storage of fat and glucose. They're going to have a hyperglycemia. So they have an intolerance to glucose. So our patients that have Cushing's are going to have really high blood glucoses. They have muscle wasting. So they have this thickened trunk and this moon-shaped face, but they have spindly extremities. They're going to have a loss of bone. They have thin, fragile skin. They have this purple striae or like stretch marks on the abdomen, the breast, and buttocks. They have an excess of body hair. And so we'll see ladies, and it's kind of hard to see on this picture, but this lady has a mustache almost as good as a gentleman's mustache. They're going to have hypertension. They have hypokalemia. And they're going to have a hypernatremia because they're saving all their water. So our diagnostics are going to be a 24-hour collection of urine cortisol, and if it's elevated, they're going to have Cushing syndrome. We can also do what's known as a dexamethasone test, which is the dexamethasone is a glucocorticoid, and it's given at 11 o'clock at night. We draw their cortisol level at 8 o'clock in the morning. And in a normal patient, the cortisol level will be low. In a patient with Cushing's, it's going to be elevated. Collaborative treatment's going to be treat the underlying cause. If it is a tumor, they're going to do an adrenalectomy. We're going to do medications to suppress our adrenal function. We're going to need to monitor that glucose and that potassium. They're going to need, patients may need an adrenalectomy, which will require high doses of steroid postoperatively. And they're going to need some psychosocial support because, again, they put on all this weight. They put on all this fat. So they're going to need a lot of psychosocial support. The opposite of Cushing syndrome is Addison's disease. And Addison's disease is an insufficiency of our glucocorticoids and our mineral corticoids. It's most often is autoimmune. It's most often in Caucasian females. We're not going to see any of the clinical symptoms till about 90% of the adrenal cortex function is lost. We're going to see weakness, fatigue, weight loss, anorexia, hyponatremia, and hyperkalemia. And that's because of those mineral corticoids, our aldosterone. We're going to be seeing some nausea and vomiting, and they're going to be hypoglycemic. Our patients that have problems with have Addison's disease can actually go into an Addisonian crisis. If they're under stress or if they're surgery, psychological stress, physical stress, they actually cannot secrete the glucocorticoids and mineral corticoids that we would normally, those of us that have normal uh, adrenal cortex, to survive. So they actually become very, very hypotensive. They're going to be hyperkalemic and hypoglycemic. I remember a gentleman I took care of the one time who had Addison's disease, and he actually, when he came in, his labs, they don't make sense. If they're dehydrated, you would expect to see a hypernatremia, but he was actually hyponatremic. And then you look at the potassium, and his potassium was like 6.8, and his glucose was 30, and no matter how much glucose I gave him, I couldn't get it up. So with our patients with Addison's disease, we want to be teaching them about their medications that they're going to be taking. Diagnostically, we're going to look at plasma cortisol levels. And then collaboratively, we want to replace the mineral corticoids and glucocorticoids. So mineral corticoids and our glucocorticoids, the medication that we use is hydrocortisone. And this gentleman, once we figured out that he was in an Addisonian crisis, he got 100 milligrams of hydrocortisone every 4 hours, and all of a sudden, it was like magic. You wouldn't have believed it. This man looked like he was knocking on death's door, and after about his third dose, he perked right up. They're going to need IV fluids. We're going to be assessing their hydration status, daily weights. The other thing is, again, with stress, infections. We know that infections can stress our body. So on patients that are ill, they're going to need to actually increase their doses of mineral corticoids and glucocorticoids so that when their body is stressed, they will be able to cover it. Corticosteroid therapy, we use this a lot. We talked about it, especially in our respiratory diseases. We've talked about it. We will be talking about it in oncology. But corticosteroid therapy, this depresses our immune response and our inflammatory. So it's immunosuppression and anti-inflammatory. We're going to see a decrease in localized redness, tenderness, heat, and swelling. And this is going to happen internally. We can also use it for maintaining blood pressure because it causes a vasoconstrictive response. It also causes sodium retention. And it also works on carbohydrate and protein metabolism. So what we're going to be watching for, first of all, is our patient is predisposed to peptic ulcer diseases. They're predisposed to osteoporosis. They're going to have a glucose intolerance, so they may even become a diabetic because of their corticosteroid therapy. Healing is going to be delayed. And then the big question is, how do you know your patient has an infection? If it's immunosuppressive and anti-inflammatory, even if they have a skin disorder or a skin rash, you may not be able to see it because it's being suppressed. With our patients that are on corticosteroid therapy, the adrenocorticotropic hormones are going to be suppressed. So we want our patients, if they're on it, to go off slowly. Blood pressure is going to be increased because of the excess blood volume and the vasoconstrictive effect. And we're going to see a protein depletion. So all of these, when we look at corticosteroid therapy, all of these can occur. So we need to be vigilant with our patients, looking at their blood sugar, looking at their immunosuppression. Their white count is not going to elevate because of the corticosteroid therapy. So you're going to need to be very vigilant on when is our patient actually ill or not. The next one we're going to talk about is a pheochromocytoma. This is a tumor of the adrenal medulla. Now, we've been talking about endocrine and the adrenal cortex, which is where we get all of our hormones. The adrenal medulla is where we get our epinephrine and our norepinephrine and our atropine and our dopamine. So all of this comes from the adrenal medulla. And so we have this overproduction of epinephrine. The clinical features of a pheochromocytoma is episodic hypertension, and it's actually a triad. It's hypertension, tachycardia, and profuse sweating. They also may complain of a headache. They can have some abdominal pain or chest pain. This can be caused by medications, antihypertensives, opioids, contrast media, tricyclic antidepressants. The attacks can last from a few minutes to several hours. The diagnostic test for pheo is urinary metanephrines, which are the catecholamine metabolites, and this is done as a 24-hour urine collection. Collaboratively, the patient, if it is because of a tumor, they're going to need an adrenalectomy. And then the last one we need to talk about is the hyperaldosteronism, which is high doses of aldosterone. This is going to cause sodium retention and excretion of potassium. Sodium retention is going to be we're going to see some hypertension. They're going to have headache. Edema doesn't usually occur because the rate of sodium excretion increases. Because the rate of sodium increases, the excretion increases, which causes more sodium retention. So we're going to see hypernatremia. We're not going to see edema. We're going to see potassium excretion. So we're going to see cardiac dysrhythmias, glucose intolerance, and metabolic acidosis. Again, hyperaldosteronism can be caused by a tumor, and so our patient is going to need an adrenalectomy, or they're going to need medications to help drop that sodium. And that's it. I hope you all have a great day.